My name's Iqbal Malik, and I'm going to take you through a Transcaval TAVI that I did at the Hammersmith Hospital in 2025. So TAVI is a transcatheter aortic valve, and there are many routes in. We use transcaval as our default strategy if the transfemoral access, which is the standard one, is not appropriate. We also use axillary access, but in my mind, if you can do a transcaval, it is a specific skill set, but actually probably safer for the patient, and there is data that it's less likely to cause a stroke and indeed bleeding. We're going to use an Abbott Navitor valve today. So first of all, let's talk through the setup of the transcaval. We need a slot, so where there's not too much calcification and less than 10 millimeters between the IVC and the aorta. We're going to put a snare into the aorta and then poke a electrified needle from the IVC inferior vena cava into the aorta at the right spot, snare that needle and wire, and then push up a thicker wire on which we can deliver a sheath through which we can do our TAVI. And on the way out, we'll plug the hole in the aorta. We don't need to plug the hole in the IVC, that settles by itself. So here's us doing the transcaval setup. On CT, we know what height to puncture at, and we've taken an aortogram, most importantly, so that we know where we're going to puncture, but also to ensure that the sizing is available for our covered stent in case we need it. Thankfully, up till now, I've never needed a covered stent, but it's certainly possible. So from the left femoral artery, I'm inserting a loop snare. The size of the loop is the size of the aorta, so that we can position it as a bullseye for our electrified wire, which we're going to use to burn a hole from the IVC to the aorta. So here's me manipulating that loop to able to get it aligned both in PA and lateral view, so we can set up a bullseye. In this particular patient, the PA and lateral views were exactly aligned, and therefore we were able to use those exact angles, but it can be any angle. And here is the lateral view showing the bullseye all set up. So into that bullseye, we need to put an Astato wire through a Finecross catheter, which has a Navicross catheter, which is inside a guide catheter, and then we can electrify the needle and burn. So it needs 3 Y connectors in a row because we need to make sure there's no bleeding while we do this procedure. We line up so that that electrified Astato wire is then ready to poke through. But before we do, we always double check. Are we at the right height? Are we going to be into the bullseye? We check both in PA and in lateral again to check the puncture height and the orientation. And once I'm happy that the zap can be applied safely, then we're ready to electrify the wire. So we've rubbed a bit of the wire coating off at the other end and applied a clamp so that a diathermy system can be used to poke through the aorta, and here it goes through the aorta. You felt it pop through into our snare. So what we then need to do is to use our snare to grab the wire, and it should be fairly straightforward, but it is a little slippery and a bit fiddly, and as you see here, as I snared it and pulled it into the catheter, it let go. So that doesn't matter because we know that that wire is in the aorta. So I've gone to the lateral view because I felt that was going to be more useful. I'm rubbing that big snare up and down to try and actually get our wire caught again. This very fine Astato wire is stiff enough to produce a rail for our Finecross catheter and then our Astato catheter. So here's me grabbing it, and once I've grabbed it, we're back in business, able to use this as a rail. And so once I've grabbed it, I'm going to switch over to the PA view again, because this lateral view produces a lot of radiation to the operator and the patient, and push. This requires a coordinated effort to push both the snare upwards without releasing it, while introducing the wire from the other end as well. So both IVC and the aorta ends are being pushed upwards so that we then get a nice bit of wire going up into the ascending aorta. So that can go all the way up, as you see here, following which we're going to try and push across the Finecross catheter. Sometimes this requires balloon dilatation with an angioplasty balloon, but in this situation, a little bit of manipulation. The Finecross pushes across, the Navicross pushes across, and then we're in the position where we can take those catheters up to the ascending aorta, so they're well inside the aorta. There's no chance of them falling out, and we can then release our wire. The wire has done its job and it can be removed, so that we can then have up the left femoral artery a pigtail catheter, and into the Navicross catheter, having removed the Finecross, we can place a stiff wire which will then act as our rail for all other equipment that goes up with our TAVI procedure. So here's our pigtail in position, and then we're going to exchange over to our stiff Amplatzer wire. Here it comes. You can see it's clearly marked, very clearly visible. And so now we have our rail, and on this rail we should be able to introduce our TAVI sheaths. Now the key thing about the sheath, it has to be long enough to be in the aorta at all times. So you're going to need about a 60 centimeter sheath, not the standard sheath. We're now ready to check the Navitor valve to make sure it's been loaded properly, and of course it invariably is, but we always check. And then we have to dilate what is a very tough skins tract in this patient. And so this is an 18 French sheath. The stiff wire is being held. Remember, the artery dives downwards, the vein dives downwards, and that's the direction we're pushing the sheath in across the aortic puncture, so that we've dilated that hole as well, while keeping a firm hold of the stiff wire. Once we've done that, that's the 18 French sheath, but it was such a tough push in the skin, I also chose to take the 22 French dilator and do exactly the same thing. You can see that the push I'm about to give is fairly brutal, but actually our patient is awake. We've given lots of local anesthetic, and he has actually had very much sedation, intravenous paracetamol. And that's enough for us to dilate through. The only painful part of this procedure is actually the the puncture in the aorta, the electrification. The patient definitely feels that, and we gave him sedation at that moment. So now the 22 French sheath is on. We need a big sheath to deliver this, this valve. And you can see again a very hard push going downwards, slow and steady. Allow it to pop through the skin, and once it's through the skin, then it was fairly plain sailing all the way up, including through the aortic puncture, as you can see going through here. That didn't really cause a problem. It was the skin that was tough. So it is a long sheath, and the dilator hopefully won't do any damage, so we're tracking it up. We then remove the dilator, and through this big sheath I've done coronary angiography. So we do CT scans in advance. It rules out proximal coronary artery disease, so we know there's not going to be a calamity that we need to suddenly stop the TAVI for. And you can see although there's atheroma in the left coronary artery and in the right coronary artery, there isn't any significant disease that we need to tackle right now. If he has symptoms in the future, we can come back to it, but there really isn't a significant stenosis here. So now we've got to the stage where it's just a TAVI. We've got access, and the rest of it is fairly plain sailing. So we need to set up an aortogram. So we can do a 3-cusp view and a cusp overlap view. The cusp overlap view means you can calibrate the height of your valve. Remember, the lower the valve, the higher the risk of pacing. The higher the valve, the higher the risk of pop-up. So we need to find the compromise, which for the Navitor valve, it has quite clear markers. So the 3-cusp view is marked out here. In fact, the right coronary catheter was in the right coronary sinus, not the not the left coronary sinus. But it's clear where the 3-cusp view was, and we're aligned. And then we've moved to the 2-cusp view. So the cusp overlap view where the right and left overlap. The non has the pigtail catheter in, and we can see that we're fairly well aligned. And this is probably what we're going to use because it's an achievable angle in this situation, REO 10 caudal 29, to deploy the valve. So of course we have to cross the valve with a straight wire, and I used the JR4 catheter here just to cross. We then switch over to a J wire, a nice soft wire after the catheter has got through, and through that we'll put a pigtail catheter and do some hemodynamics. Not every cath lab does that, but I think it's very important to do hemodynamics carefully before and after, especially when you don't have general anesthetic or transesophageal echo to assess the quality of your result. So here come the hemodynamics, and it's not the largest gradient in the world, but remember, he's a bit dehydrated, he is mildly sedated, he's horizontal. It's a narrow complex ECG with a gradient of about 30 across the valve. We test pacing, So I'm pacing at 180, 200 beats a minute. Make sure that I can get good capture for when I need to actually do pacing for the balloon dilatation that I'm going to do prior to deploying the Navitor valve. This is a highly calcified valve, so I've taken a 20 millimeter balloon here. We've done rapid pacing, we've inflated, you can see a hard push on an inflator while we inflate the balloon in position. So that's caught the valve, it's expanded, and so I think we should be able to get our Navitor valve into position without difficulty, and hopefully won't need to post dilate. So the Navitor valve is actually a very slim valve, and it went into the sheath perfectly adequately and without any difficulty whatsoever. And it's an inline sheath, which is now inside our sheath, and so we'll then align if possible. So in LAO we can see if there's one marker on the inner curve and two markers on the outer curve. Now, can we align any of these valves? I think it's difficult. We can do our best in the LAO position, but by the time it's twisted around the arch of the aorta into the ascending aorta, it is actually quite difficult to be sure they're aligned at that stage. But we've done our best here, and it's certainly aligned as we go onto the LAO position. But as you see, there's a very hard push coming up to get it around the arch of the aorta into the ascending, and by that time I think we've got a bit of lack of orientation, so we're going to target just making the height correct to minimize pacing. And we've got a stiff safari wire in, and you have to hold the wire carefully, a bit of push and pull to get this very deliverable valve around the arch of the aorta. Other valves can be a bit stiffer. The Edwards is a bit steerable, the Medtronic is not steerable at all. This one is more flexible and not a bad choice in this particular patient. So we've looked at the 3-cusp view, and the height is reasonable. It'll drift down a little bit as we deploy. And then we've looked in the 2-cusp view to see that we can also check that the height is good there. And this looks actually very good. And we're going to use the cusp overlap view to do our deployment. The deployment is with just a rotation of the blue wheel, and as we rotate, the valve will slowly start to open up, and actually with very little change in hemodynamics, even though this is an intra-annular valve. So you can see the sheath is coming back, the valve is about to flower open. We're controlling the height. I always hold the wire and the catheter itself to control the height, while someone else opens the wheel to deploy the valve in position. But you can see that, as often happens, although one of our markers is exactly at the right height in the non-coronary sinus, another one of the markers is lifted quite out of the annular plane. And this is not uncommon. It doesn't mean you've got it wrong. It's just the valve is opening in a slightly eccentric fashion. And so we're going to persist, because I think the height is correct, both in the non and on the cusp overlap sinus on the other side. And the third marker is high just because it's opening in a slightly angulated fashion. So we're going to take our first shot in that view. I think the height was reasonable in the non-coronary sinus, but I can't be certain exactly how it's deployed. So we're going to try and get a better view. So here's another view. So we've taken another view to try and align things. I think the height is safe, but I'm still not absolutely certain about the third cusp. So here's an LAO view, and I think this shows actually a very good height. It does show the alignment not so good, but it shows a very good height. And so we then press the button, which you can see there, and then that allows us to continue the rotation to finally release the valve. That's a safety button. And so as we slowly release now, and we're doing it very slowly, I've got control of the wire and the catheter, so I can control the tension in the system, and we're very slowly going to rotate the capsule off and wait for all 3 of the clamps to be actually released at the top end to make sure that the valve is going to be completely free. There's no rush at this time. We're taking our time. It's still not fully released itself. You'll see that as it flowers completely, which is about there, that it's probably fully released now. I don't normally move the pigtail. I want to see exactly what the height is. I've never trapped a pigtail properly down there. The height looks actually very, very good. I can't see any aortic regurgitation. I can see some flow in the left coronary artery as well, which is always great. So I'm happy with this position. Not that we could rescue it in any case, because we fully released it. And then we have to do some manipulation to make sure that the nose cone does not pull this valve out. So there's no steerability, so the control of the nose cone is with the wire and with the catheter. So using different positions of the wire, some rotations of the catheter, I'm just gently easing the nose cone out so that we can then be sure that the valve remains unmoved while the system, the delivery system, is slowly removed. Again, there's no rushing this part. We're taking it nice and slowly. And here it is, the nose cone is popping itself through. And we take our time and slowly ease it out. And the pigtail actually is a very good marker to say that the valve is not moving at all. So we then can recapture the delivery system. If it wasn't such a big sheath, then there is a mechanism to make it make things as small as possible. Here is the nose cone being drawn in against the catheter. Then the catheter itself is then fully withdrawn into the very large sheath. It then hits the inline sheath, and then we're out of the body. So the hemodynamics now show there's no gradient, that the coronary perfusion pressure is maintained. There's a good dicrotic notch, so I'm happy. However, we've still got a big hole in the aorta, and so that is an ADO device, usually a 10x8, inside an agilis sheath, so it allows to give direction, and that is slowly withdrawn. But remember, I've already put a safety wire in, which is a BMW wire. In case everything pulls out, I can get back into the aorta very easily. So I'm drawing the agilis and the big sheath downwards. The agilis is just slightly longer than the 60 centimeter sheath, so we can manipulate it. That big sheath is better out of the aorta and actually into the IVC if at all possible. So we're now about to deploy the disc of the ADO device, and you can see it slowly coming out. And so it's just going to form its disc. It just did it there, but I've kept the waist in. Now this is exactly at the wrong angle. It's completely across the aorta. We want it angled in the direction of the aorta, and so I'm now tugging, and as I tug, it's going to come and align itself against the aortic valve. You can see that's a wrong angle, but as I tug, it becomes the right angle. I've steered the agilis sheath to do it as well, and then at this point the waist of the device will close the hole, and so I'm deploying the device just by pulling the agilis sheath back, and then we can check our position. We can still recapture it if we need to. Is that angle as good as it might be? I think the disc is still a little bit proud into the aorta, and so I'm going to give it another chance and see if I can recapture it, and then pull it against the aorta a bit more. And so here's me drawing it in, and once I've drawn it in, you can see it can be recaptured as such. I've pulled the disc even further against the wall and deployed it again. It's a very small change, perhaps not essential, but it made me happier that I was in a better position. And although there's a little bit of contrast going into the IVC, that doesn't matter, that's absolutely fine. And then I've released the ADO device, I've taken out my safety wire, I've pulled the sheath into the IVC, and then taken that very large sheath out. I pre-closed the vein with 2 ProGlides, and I'm going to use those just to close this up completely and reverse the heparin at this stage, because we want clean bleeding points. The valve is in, and an echo check showed it was absolutely fine. The left leg I'm going to close with an angioseal device. I've done an angiogram at the start of this femoral puncture under ultrasound and showed it was a clean puncture, so an angioseal. And then the venous puncture on the other side I've closed with a ProGlide suture. So all in all, a successful procedure. It took just over an hour. The patient was awake with intravenous paracetamol sedation for just the zap, but no real other part of the procedure, and he tolerated it very well. We watched him for 48 hours and he went home. So thanks for joining me for a successful Transcaval Abbott valve, and I look forward to seeing you again next time.